Welcome to the AT and Osteo Chronicles. I'm Brynn Bicknell, and I'm a certified athletic therapist.
And I'm Jenna Howe, and I am a manual osteopathic practitioner.
Today, we decided to write down a few questions or concerns that people may have for us, and we're going to randomly select them and answer today.
Yes, I love this. So it's like a like rehab roulette, except we don't have a roulette wheel. It's like little jars.
Yeah.
All right. So, um, I'll pick one first.
Okay.
Let's see. So these are like commonly asked questions that Bryn and I would get in our practice. Okay. Why are you working on my big toe when my neck is the problem? All right, Bryn, let's hear your perspective first, and then I'll go through my perspective.
So, the big toe is really important in gait. And what that means is when we're walking, if we can't lift up our big toe and move it, then we compensate with our hip. And if we compensate with our hip, that shifts our body and can affect the spine all the way up to the neck. So it's one of those pathways where most people don't see the connection, where when we're working on the neck and we notice that it's not being addressed, we know that the root cause is coming from somewhere else in the body. So going to the big toe is something that I tend to look at.
Yeah, that's interesting. I would say probably pretty much the same for me. What I end up maybe describing to my clients in session is, and I'm a very visual person, so I've got my kinetic chains charts on the wall. I have my anatomy trains book, and so I'll open up the fascial lines. So I'll show people the kinetic movement um, chains, and I'll show them on the chart how the foot and the neck are linked in a kinetic pattern. Like you said, like with gait. So whether it's in the front of the body or the back of the body, just showing them how that's connected. And sometimes I'll show them how the fascia runs. Depends on what we're looking at, but from the foot either up to the neck or up through the back side of the body or the front side of the body. So I tend to look at those kinds of things. But yeah, if the big toe is not moving well, then as you said, it travels up to the hip, and maybe the hip's not moving well, and then it's going to travel up all the way. And so when somebody doesn't, if they still can't quite understand how they're linked, that's when I pull out the charts.
Yeah.
And then I
Visual,
do visual.
visually it helps. Yeah.
And I do a lot of neurokinetic assessment. And so what I do find with neurokinetic assessment as opposed to an orthopedic assessment is that if their hip flexor is weak and their big toe, if I mobilize the big toe, and then all of a sudden their hip flexor goes strong again, they can feel the relationship there, and then we just travel that all the way up, and then they can feel like, oh, my neck is relaxed, but you didn't touch my neck, you only really worked on my hip and my toe. uh and then it kind of goes from there. So hopefully that will help other people understand a little bit more about why their therapist is working on the complete opposite end of the body from where they came in with.
Yes. Okay. So I am gonna pick something. I've gotten this a couple times recently.
Okay.
I rolled my ankle. What should I do before my next appointment?
Ooh, that's a good one.
Yeah. So the first thing that I have people do is I know that ice is a bit controversial, but I find that putting your foot in a bucket of ice water for 5 to 10 minutes helps with the swelling. And then after that, you're supposed to move it in a pain-free range. So up, down, side to side, and circles. You can also write out your name a couple times. And doing this will help move the swelling out of the foot and keeping your range of motion. And then you're able to recover quicker, walk on it sooner, and return back to daily life.
Yeah, I guess for me, I usually am working more with the chronic situation. So this feels like it's more of an athletic therapy realm as far as like scope of practice, that kind of thing. Um, but if I have a current client who mentions, oh, I sprained my ankle or I rolled my ankle, what should I do? Kind of similar. I never really thought about the ice bucket. Again, I'm not an acute injury, so that doesn't come to mind. But I usually say that like blood flow is your friend, so non-weight bearing, like you said, like just moving the ankle around, that kind of thing, and anything that's providing general comfort. So if cold is comforting, if cold makes you feel better, put cold on it, and I might describe to them more of the current methodology on ice, but then also saying comfort is great. Like
Yeah.
you need to be comfortable,
Yeah.
right? Like whatever feels best to you. Um, yeah. And then I would, but in with manual osteopathy, I might, if it's a regular client, I might get them to come on in and I might do the Bowen therapy ankle procedure and then I might tape it gently. So not like an AT taping, but more of a like general kin taping just to provide some proprioception. So that's
Yeah.
probably what I would do.
For lymphatic drainage. Yeah.
Yeah.
Perfect.
And then check compensation patterns up the chain.
Oh yeah. Once they come in, then it's like we have to check everything. Why'd you roll that ankle? What's going on in your body?
Yeah, yeah,
And then after they roll the ankle, usually it's the talus shifts a lot of the time because the ligaments become loose. So it's about that's where the bow and ankle addresses the talus. And then, like you said, compensation patterns. When you start limping, your hips shift, your ribs shift over to balance that out. And just looking at what muscles may not have been firing properly in the ankle as well
yeah.
with your NKT.
Yeah, well, I think that's where osteopathy and athletic therapy like beautifully go together because with athletic therapy you have the immediate, the acute, like that type of thing, which is really necessary. But osteopathy really shines when it comes to the compensation patterns that arise after a structural issue has come into the system. So yeah, it just pairs so nicely. AT and osteopathy for sure. Okay, so my next one. How would you address knee pain? So knee pain is pretty general, but it's a common question. And you just see people on their intake form, just I have knee pain. And sometimes they have a diagnosis of arthritis. Sometimes they've already been to see someone, say, for an ACL tear or meniscus or something like that. I tend to get a lot of people who my knee hurts, and I don't know why. So, how I address knee pain is I do want to see from a structural perspective and also osteopathically, I'll do like a general listening, which we can dive into that maybe in a different conversation in terms of our assessment, various assessment techniques. But a general listening gives me an idea where there's a fascial pull. Um, towards a somatic dysfunction, which might be taking me right towards the knee, or it might take me to where it's a compensation issue regarding the knee. Um, and so this is where I kind of combine principles based and techniques based osteopathy because I do want to see the whole picture, but I'm not going to ignore the reason why you came in. So I'll do my listening techniques, and then when you're actually on the table, up until then, so I might also ask somebody what movements hurt and let me see it, that kind of thing. So I'm doing a structural check, I'm doing like a bit of a fascial check, and then on the table, I'm doing a palpation. So I want to know, is the knee more swollen? Is there more heat coming out of the knee? I look at those kinds of things. I look at some fascial restrictions from laying down on the table. and whether or not that's going to take me to the hip first or the ankle first or directly to the knee. Um, Once I've kind of gone through all of that, then I'll do some specific muscle testing for the knee. So quadriceps, hamstrings, glutes, adductors, all the areas that could impact the knee. I've also done some fascial restriction from a movement perspective. So then I'm looking at if I'm looking at this knee, what's happening at the opposite shoulder. I'm taking into account their history. Have they hurt their opposite shoulder? Have they hurt their hip before? What's their mobility in their ankle like? So that's what I'm doing first, is I'm just going through every system. If required, I might do a visceral check. Excuse me, because sometimes nerves can get trapped in the abdomen and in through the hips, because maybe the visceral region, maybe they've got a diaphragmatic dysfunction and it's putting pressure on the organs, which is putting pressure on the nerves, which is then feeding down into the knee. From a neural perspective, I might be checking, is the femoral nerve trapped that's feeding down into the knee. So I'm doing all of that first. That helps me localize where I want to work first. And then the techniques might be mobilization, might be fascial work, might be soft tissue, Bowen stuff. It might be nerve. Um, yeah. And then we get those muscles strong. We feel what the compensation patterns are. And then I develop the home program. I think hopefully that didn't sound too confusing. But from an osteopathic lens, we're kind of going from the outside and boiling it all the way down and then coming it all the way back out again. So it's a real systems approach with osteopathy, because we need to see how many things are feeding into the knee. Oftentimes, the knee problem is not just the knee. Now, if they've come in and said, I was playing soccer and I blew out my ACL and my physio discharged me, but I'm still in pain, I may just start there and work my way up.
So I'm glad you said that because that's kind of where I was going to go with it too. Unless you've had some traumatic injury at the knee, most of the time it's coming from either the foot or the hip. And
Yeah.
so it's one of those things where I might work on the knee a little bit for a little bit of the swelling, or if you have a specific area where you feel that pull or tension. But most people I find that come in with knee pain are patellofemoral syndrome, which really means a biomechanical pain that they don't really know how to identify that's not actually coming from the knee. That's just where you're feeling it. And so it's really looking at the foot and how the foot is positioned and the muscles are working there and pulling on the knee and the hip. And like you said, it could be coming from a hip issue, which could lead to more systems because, like we know, at the hip, we have tons of blood vessels, nerves, the organs are there as well. I don't have a ton of background in that, but I find that when we balance the body, we can localize specifically what's now left at the knee.
Yeah.
Yeah.
Yeah. And
I don't know if that helps.
oh, absolutely. Well, and because knee pain can be general. And if it's arthritis, well, the key with arthritis is just movement, blood flow. Let's just try to keep blood moving through the joint.
Hmm.
But chances are, if I've checked the hip, that hip is super restricted.
Yes. And yeah, arthritis is because there's like bony stuff rubbing. And so if we can align it the best way possible for the meniscus to move in there, then you're not going to be in as much pain.
Yeah. Um, a topic I think we should address another time, and I'm just going to say it on camera so that we don't forget, because I will forget, is postmenopausal women and hip pain.
Okay.
Yeah.
Perfect.
So tune
Write
in.
that down. Take a note.
Yeah.
All right.
Um,
I'm going to read another
okay.
one. What do you do for your own neck pain slash tension?
You want me to go first?
It's totally up to you.
Um, what I do for my neck, uh, I use a lot of um, cold spray or cold, like a, like a roll. I don't know what I'm saying. Um, Yeah, like biofreeze or cryoderm
Okay.
or something. I find for me, my body really likes that. I'll do some self manipulation of the neck, and I'll do some gentle stretching, and I'll just try to keep things moving. So, I don't want to force a range of motion. Sometimes I'll do some gentle muscle energy techniques on myself going in each direction. I do a lot of Bowen moves on myself, which I've shown a few of my patients over time how to do that. But I find my go-to comfort is BioFreeze. I really,
Biofreeze.
I
Okay.
don't, I don't travel without it.
Yeah, I would say that I do MET on myself, Bowen on myself. And then the other thing that I do is I find that I try to work on stabilization. So of my upper back, because I notice that it's like my pain tends to be more here. And so
Mm,
I will work on upper back stabilizing exercises as well, because I find that that provides me more support.
yeah. I tend to focus on my posture. So if my neck is starting to get sore, I've probably done something like
Hmm.
that, like we tend to
Yeah.
all do. So then I kind of just remind myself
Yes.
to kind of go back to just the same thing I do with my patients. It's like, no, none of us are perfect. You can't ever have perfect posture. Bad posture doesn't necessarily mean you always have pain, but sometimes when you have pain, if you adjust your posture, it can help to alleviate those tension patterns, right? So if your head is
Yes.
not weighing heavy on your neck, then it stands to reason that, again, like you said, better stabilization and it just takes the pressure off. So that's also
Yeah.
what I do is I try to give myself my own kick in the pants about my posture. If my neck is sore, then I'm probably sitting in a weird way or something like that.
Yeah. I've also found that activating my core, the deep core, will also alleviate some of that pressure on the neck.
Yeah. Which, shameless plug, you'll probably address in your Pilates rehab class.
Yay! Yes, coming
Also
soon.
tune in. You think, okay.
That was perfect timing. Well,
Okay. What's the next one? How do you help whiplash? Okay. So what I do for whiplash is a little bit different than what I used to do for whiplash. So now I'll actually do a neural assessment first. Um, it's a bit harder to describe, but the neural manipulation is a really gentle assessment of the nerves, peripheral nerves coming up into the head and then down into the legs and the spine. And so we have the dural tube. So it's different than cranial sacral therapy. So how I look at it from a whiplash perspective is I'm looking at the dural tube and the nerves and the dura that's coming up into the brain. So I actually will assess that first and clear that dysfunction, or as best I can, create some sense of homeostasis in the system from that perspective. And then I'll actually do more muscle assessment. Or sometimes, not to get too confusing, I'll do my muscle assessment first, figure out what muscles of the neck are weak. So traditionally, not always, but traditionally, it's because the cervical muscles are overworking for the neck flexors. And then there's some other stuff going on, depends if it's a rotational whiplash or forward and back. So I'll figure out what's weak and then I'll actually go do the neural assessment. I will work on what needs to be worked on there. I'll come back to the muscle assessment, see what's residual, and then fine tune the muscle pairing from there. So that's how I treat whiplash, and then I'll give a home program from that. Um, I mean, it's so common. It's not just car accident. It can happen. I've worked on people who fell on the ice, fell down the stairs, um, fell in the bathtub, all that kind of stuff. So that's how I treat whiplash now. Um, but I'm also looking for downstream effects. So it's not just the neck. It can sometimes go all the way down the spine, right into the sacrum. And so I will be also checking that whole system just to see what else is going on.
So it depends. I find that's my answer for a lot of things. If people come in with whiplash and they've seen other people and there's just something lingering, I will go more of what's going on in the site, looking for the lesions, potentially doing some muscle energy, and then, like you said, muscle testing for with neurokinetic therapy to figure out what's weak and strong. If somebody's coming in and it's just happened and they're very overwhelmed, I go with a nervous system reset and then I assess the spine. Because, like you said, if one part's off, and that's usually what happens when people have so many so many things that are off, is that or symptoms, is because one of the vertebrae is not sitting properly at the in the cervical spine, and so there's a lesion, and then when that happens, the sacrum will compensate. So it's about correcting those and then figuring out what's going on after we've done that.
Yeah, that's like the Lovett brothers connection, right? From the
Yeah.
cervical to the lumbar. Um, yeah, and what I will say is that if someone calls me and they were whiplash 2 days ago, I'll book them a week from then. I want at least 5 days post whiplash or post incident before I'm even touching them. Ideally, they've gone and had a proper diagnosis somewhere else medically, um, because I have found that it can take up to 5 days for the full effect of that whiplash action to even get into their nervous system. And so I want to be super conservative with it, and not provoke them too much. If they're insistent on coming in anyway, I may do very little at the actual neck. And like you said, just go down to the spine, down to the lower back, try to like make sure that's all nice and happy, sets the stage for things to create a healing effect. That's the one thing that I've learned with osteopathy is that, especially when it comes to nerve related stuff, is you don't have to work on the specific area in order to create a positive effect in somebody's system. The nerves kind of know what you want them to do, really. Like the nerves are all attached. So if you're working on the nerves on the lower end of the spine that's not so sore and they're not so freaked out, you can still gain a lot of progress with their pain and discomfort.
Yeah, I would definitely agree with that. Your body wants to be in that homeostasis or where it's fully balanced. So it's trying to get there. All we're doing is guiding it, and then you're doing the rest.
Yeah, exactly.
Okay. Why is it so important for me to walk and hydrate after a session?
Ooh.
So, especially after a concussion session, movement is needed. The body is trying to go back to that homeostasis or balanced state. And in order for it to do that, you have to have movement. Movement moves the lymph, and the lymph removes the waste in the body or the excess that you don't need. And the only way for the lymph to move is for the muscles to move. They're similar to the veins. And so that's why we say hydrate, to give extra fluid to help get that lymph moving.
Yeah, and I find if it's not concussion related and it's more just more mechanical stuff, knee, hip, back, shoulder, whatever. Anytime that you're doing something on the body, it creates a bit of a proprioceptive change. And so when we get people to come up and walk, you're integrating the new messaging, the proprioception, because it can throw your body a little bit off kilter And so you don't want somebody to just to kind of also bolt right out the door and they're feeling a little wobbly. So I like to do a lot of like walking in the office. Let me see how it feels. Like just give the body a chance to go, okay, all right, you did this work on my knee or my neck or whatever it is. How does that feel in my body now? Um, and then again, keeping that general movement. And it's sort of the same thing with the hydration. Um, anytime we're asking our body to do anything, so with exercise, massage, chiro, whatever we're doing, is we're asking it for resources. And so bringing water back into the system means we're also replenishing what was used for those resources when we were moving things around. It
Yes.
delivered nutrients to the area. It's, all the wonderful things, right? In terms of increasing our lymphatic system and our circulatory system. Just that replenishment. And fascia, making sure that the fascia, I think it's, widely known now that is part of our sort of our hydration delivery system to areas of the month. It's like a little highway. So we want to make sure that's fully hydrated as well. So you get the best benefit out of your treatment, either in session and or outside of the session in between sessions as well.
Yeah. And our bodies just love it when we move.
Yeah.
Yeah.
Movement really is, um, I I know it's like a coined term, but movement is medicine. It really is. And I think it just always has been. Um, I do think we could talk at another time about movement as we age.
That would be a great topic.
Yeah, because I
This
find,
session is having a bunch of things opening up for us in the future.
yeah, yeah, because movement as we age, from what I see a lot of people who are over the age of 65 who are doing a lot of movement. But things are starting to shift for them physically. And so much of it is about finding that balance of how they moved when they were 40 to how they can keep moving when they're in their 70s and 80s. So I think that'll be a great topic. Got two great topics coming up. Uh,
Okay.
okay. Well,
Um,
that's been a lot of questions. Hopefully, it's
yes.
been really helpful for a lot of people. There are questions that we get in our offices for sure, that are pretty consistent. So we wanted to share this with everybody, so that hopefully it can help people answer some of those questions that maybe they haven't asked their practitioners as of yet.
Yeah. Thanks for joining us and tune into our next sessions to hear more.